Welcome to podcast 8.
I'm Fran.
And I'm Minnie.
And as always, please do feedback to us using the scoring system, which is anonymous. And of course, you're welcome to add any comments, both positive or constructive. So today's topic is pneumonia in the under fives and paediatric respiratory history taking.
And today's podcast tip is to refer any complicated cases to our paediatric volunteers, as we have a few of those who are extremely good at giving you helpful advice.
Brilliant. And so why are we talking about this, Minnie?
Well, in children, Fran, respiratory symptoms are very common, and pneumonia particularly remains the leading cause of death in under fives worldwide still.
Gosh. Yeah, and we know that children and infants are very different from adults. So with this podcast, we're hoping to point out key points in the history to ask, particularly in the non-verbal child, which can always be a little bit more challenging.
That's right.
Also key points in the examination, which is going to alert us to the seriousness of the child's condition. And these are sometimes called red flags or alarming symptoms or signs.
Okay, so as we've done in previous podcasts, we'll give you just a little scenario of a case that you might see in clinic, and then talk about the history that is important and the assessment and things as we go through. So the scenario this podcast is that a mother's brought her son, Joseph, who's 18 months old, to see you, and he is suffering with cough and fever. So Fran, in the history, what sort of things do you think we should particularly, other than the usual respiratory history that you would take, what things do you think we need to think about?
So we thought about things that would maybe alert us to something other than a straightforward respiratory or pneumonia condition. So if the cough had started at age less than 3 months, it could suggest there's a congenital abnormality. If the cough had an incredibly sudden onset, it could suggest there's a foreign body inhalation.
So
in England,
that's
Lego.
That's usually in children that are probably over 6 months old, when they've started to put things in their mouths, particularly.
Absolutely. Failure to thrive or faltering growth suggests some sort of chronic underlying condition that's affecting that child's growth. Cough during feeding or having problems with the suck and swallow might make you think that it could be an aspiration cause. And then coughs after feeding, particularly with small babies, if they're spitting up, retching, back arching, that might be gastroesophageal reflux. So just to be alert to these other symptoms, which might be something other than just a straightforward respiratory problem.
Yeah, that's really important actually, because particularly in the young, there are numerous things that can be a problem with congenital abnormalities, or things like cystic fibrosis or HIV or congenital heart disease. So those things just to keep in the back of your mind.
Absolutely, yeah. And then what things in the history would alarm us, Minnie?
Okay, so to make us think about worrying symptoms, we'll ask about feeding particularly. So you want to find out how well the baby's feeding, particularly if it's a breastfed or bottle-fed baby solely, because young babies are obligate nose breathers, so they don't breathe through their mouth when they're feeding, just through their noses. So if they're struggling to get their breath, they will struggle to feed, and that is a symptom that the parents may well notice, that the frequency of feeds may be reduced, or the length of time of the feeds may be reduced. And they may notice that the child is more sleepy because they're having to make more effort to actually feed as well.
Yeah, and then as a consequence of that, they'll very often have reduced output. So asking about nappies, if they're wearing them, is incredibly helpful, because that gives you an idea of the hydration status.
Yeah. So particularly ask about dry nappies as well, if they've had lots of dry nappies. As I mentioned, increased sleepiness or drowsiness. If they notice a grunting when the child's breathing, that is another indication of increased effort. And also if they've noticed any that the child is breathing quickly or panting, and any intercostal recession. So if they notice that the child's ribs are showing more when they're breathing. Also, if they're cool around the edges, if their fontanelle is depressed, if their fontanelle's still open or bulging. Both these are signs that either of underhydration or of a more serious infection like meningitis with a bulging fontanelle.
Yeah, absolutely. And fever as well, isn't it? For,
Yes.
but if the fever's gone on for longer than 5 days. So very often, small children, when they get fevers, they get a lot of viral illnesses. But if that fever is persisting for more than 5 days, then you need to be worrying about that.
That's right. I think the statistic is about 6 to 8 viral infections in any sort of viral season. So in the winter, most toddlers will get 6 to 8 upper respiratory tract infections, so it can be quite difficult to pick these apart from a more serious infection sometimes.
Yeah, I think that's really true. And then, of course, really important to ask about the environment. Has this child had any exposure to TB? Have they got exposure to smoking at home, air pollution perhaps from the method of cooking, mold? Check their immunisations are up to date, and also measure and document the child's height. Now, in the UK, we use WHO growth charts. I don't know if you have those in Zambia, but they can be found on the internet. We can maybe put a link for that.
Yeah, I think that's a good idea, because it's useful to have a trend for a lot of children, particularly if they're repeatedly coming to see you with respiratory symptoms.
Yeah, definitely. Right.
Okay, so we'll move on from the history to the assessment of a child, and this can be done quickly and with minimal intervention. And you can gain an awful lot of information just by watching the child sitting on or lying on their mother's lap, and just watch them quietly for a minute and take in what you can see and hear. So you want to listen, is there any stridor? So that's the inspiratory sound or wheeze present. Is the child drooling? So this could be a sign of foreign body or epiglottitis if they're very sick. Yeah. And count the respiratory rate for 1 minute without upsetting the child, so you get a really good...
This is always really tricky to do, isn't it, without upsetting them? But absolutely, right. you need to get an accurate measure. And, are they tachypneic, which means they have an increased respiratory rate? And the difficulty is that the normal rate changes with age. And
with which book you look at as well.
Yes, slightly that. And Vinny, you mentioned that with a malnourished child that changes? Yeah,
it's recommended that you reduce the breaths by 5 per minute, the threshold where you feel it's abnormal. So it's a lower rate would be more worrying in a malnourished child. I think that's really because they tire more quickly and have less reserve. So it's just an indication to intervene more quickly.
Got you. Okay, so it's not that their normal breathing is slower, it's that you worry at a lower level.
A lower threshold, yeah.
Got you. So. Okay, all right, thank you. So we'll put, again, this will be up in the document that comes with the podcast, but the normal rates from 0 to 6 months, you're looking at a normal breathing rate of 30 to 60 breaths per minute. Toddlers, 24 to 40 breaths per minute. 2 to 5 year olds, 20 to 30. And really from 6 years on, they have similar to an adult, which is between 12 and 20.
Yeah. So the other thing we're looking for is signs of respiratory distress. So we need to know what we're particularly looking for, which will show us that the child is beginning to have significant difficulties, really.
Yes. So what would they be?
Well, intercostal recession or retraction. So that's where you see indrawing between the ribs. Tracheal tug, which you will notice at the top of the chest in the dip where the clavicles meet. You'll see that sucking in with each breath. Nasal flaring, so that's the nostrils flaring in and out with breathing. In young babies, you may well see head bobbing and not much else. And grunting on expiration is sort of as they're struggling to keep their alveoli open. Prolonged expiration and paradoxical breathing. So this is where the abdomen seesaws in and out opposite to the chest, which is, when you've seen it once, you'll definitely know what it is.
Okay, so these are all signs, aren't they, Minnie, that child is really struggling with their breathing and you need to be doing something soon.
That's right.
to be helping, yeah. And then more worrying signs. So that's the kind of, this is worrying, and then the, oh my goodness me, this child is very ill. So the late signs of respiratory distress, what are they?
So these are just looking at the child, you'll notice that their skin colour has changed. They may be dusky, peripherally and centrally cyanosed. The peripheries will feel cold, and this coldness may be creeping centrally, so creeping up into the trunk of the body. When you listen to the chest, you may note that there's no air entry. So despite the child trying to breathe, that there is actually no gas exchange going on.
And that's called a silent chest, isn't it?
That's right, yeah. And in young babies, often, rather than their respiratory rate increasing, you may find that they're having apneas. So these are episodes where there's no breathing at all, and they just have a sort of pause, and they can be quite alarming to see. Or irregular respiration, and again, this is another sign of exhaustion. Changes in their conscious level, so more drowsy, and initially, when you're having respiratory distress, you'll notice that the heart rate, which I didn't mention before, is increasing. But in a late sign of respiratory distress is in fact a bradycardia, so the heart rate starts to drop.
Right. So it's really important, isn't it, to not just do the observations, as in, the pulse rate and the respiratory rate, but also to look at the child. And if you have any of this information, then it's really valuable to pass that on when you're asking for email advice from a virtual doctor.
Absolutely. And the other thing is to note when you're with a child, if things change. So seeing the trend is very useful as well.
Yes, absolutely.
Okay, so we'll go on to listen to the chest, and as you would, you're listening.
Oh, sorry, that's my cough. Apologies.
You're listening for decreased air entry, and crepitations or sounds within the chest. So looking for, particularly in a child that you think may have pneumonia, you're particularly listening for crepitations or reduced air entry.
Yeah. So if we're seeing a child that is in respiratory distress, the most important thing is that we need to be stabilizing them and treating them. So there's, that if they have any of these signs, you need to be thinking, do they need oxygen? Do I need to be giving antibiotics quickly? Do they need an ambulance? That it's a very quick assessment when a child is that poorly, right, before you move on to treat them. Yeah. And then once they're stable, you can always go back to examine them. So, it's a very quick listen to their chest, and then once you've stabilised them a bit, you could always go back and auscultate again.
Exactly, Fran. That's really important. So don't feel that you've got to complete the whole assessment before you actually intervene and give sometimes life-saving treatment.
Absolutely, yeah.
So if we go back to our little friend Joseph, the history his mother gives you is that he's been well until about 3 days ago, and then he started to cough and have a fever, and he's not been feeding as well. He's unsettled. She's noticed he's breathing quite quickly, and with his cough he's sometimes sick. He's passing urine fine, and as far as his development and growth is, he's normal. There's been no concerns there, and there's no family history of TB. Right. And then if we think about the assessment, when you've assessed Joseph, his respiratory rate is slightly raised at 40. He's got a temperature of 38.5 with a pulse of 120. There's no cyanosis. And if you can measure oxygen saturations, I don't know how many of you have availability to an oxygen saturation monitor. If the saturations are greater than 92, then that's okay. But 92 or below, you would want to start giving supplemental oxygen. Because cyanosis obviously is a later sign. So you need to think about that. But certainly in this case, Joseph doesn't look like he needs oxygen, and he's got some crepitations in his left lower base. Okay.
So would you do further tests, Minnie?
No. In a case like Joseph, he's quite straightforward in that it seems a very clear-cut pneumonia. So the British Thoracic Society recommends no further investigations at all. So no blood tests, no chest x-ray. The recommendation is to get on and treat, so start antibiotics, and review or give family advice when to come back to you if things aren't improving. And we're going to talk about that.
And that's interesting, isn't it? So certainly with chest x-ray, awful less in children because of the exposure to radiation.
Yeah. Okay, so if we just quickly mention the common causes of pneumonia, what are those, Fran?
So it's a whole range of infectious agents. So viruses, which we talked about, bacteria, which is what most of us normally think of, and fungi. So the most common infection is Streptococcus pneumoniae, followed by Hib, and then followed by respiratory syncytial virus. And in fact, that accounts for an awful lot in the UK, for 30 to 67% of under 1-year-olds in the UK. And then children who have HIV, obviously there's a range, I'm not sure I can pronounce that, Pneumocystis jirovecii, is that how you say it, Mary?
I think they checked, because it used to be pneumococcus, didn't it? And that was easy.
Okay, pneumococcus is one of the most common causes, and unfortunately is responsible for at least a quarter of pneumonia deaths in HIV children. So just be a little bit mindful of that one.
I meant pneumocystis, of course, not pneumococcus, didn't I?
Yes, you did.
Yes.
Thank you.
So
well
sorry
done.
about that.
Brilliant. So what does that? What does it mean for treatment, Minnie? What do we mostly do?
So the treatment of choice is amoxicillin, and that's effective against most pathogens, and most children can be treated safely and effectively with oral medication. Alternatives to amoxicillin are erythromycin, coamoxiclav or cefaclor, depending on what you have available in your setting, and treat for 5 to 7 days. Mm-hmm. However, if there's no improvement after 2 or 3 days, you can add in erythromycin or azithromycin. And obviously, if there's deterioration, then you might consider to admit to hospital.
Yeah, absolutely. And we'd use the macrolide, so that's erythromycin, family drugs, if we suspect mycoplasma or chlamydia. Yeah.
Yeah. So in an extremely ill child, or if they have signs of septicemia or a complicated pneumonia, or they can't tolerate fluids or absorb their oral medication, you would then consider giving IV, so intravenous antibiotics. And again, amoxicillin would be your first choice, or cefuroxime or cefotaxime, something like that.
Yeah. Brilliant. And as you mentioned, Minnie, you know that if you think their oxygen saturations are less than 92%, if you're able to measure them, that's the cutoff for children, at which point you'd be giving them oxygen.
That's it, exactly. So if your child's well enough to go home, as in the case of Joseph, you do still need to give the family and carers advice to safety net, so that if they do deteriorate, so looking out for signs of increased respiratory distress, which you can describe to them, feeding difficulties, or if they're not improving or the fever's persisting after 48 hours, that they should seek further help from healthcare. And also give them advice on regularly giving the medication, managing the fever with paracetamol, and giving them plenty of fluids.
Mm. Yeah, and that's interesting, Minnie. So you mentioned safety netting, and that's a phrase that we use a lot in the UK. Mm-hmm. I don't know if it's used in Zambia. So that's about giving the parent, the patient, the caregiver, whoever it is, enough information so that they are safe to go home, but they know what signs to look for and when to re-present. So it's a really important thing that they understand that, you know, so they don't just go off and say, well, I've got treatment, that's it. They realise that if things aren't improving, that they need to come back, and what signs or symptoms to look out for. Yeah,
absolutely.
So
sorry, go on.
Sometimes, unfortunately, they don't get better. Children don't get better. So I think if there are complications from the pneumonia, or it just doesn't seem to be improving, is to take more of a history, re-examine again, and consider additional things. So could there be a pleural effusion, which is when there's fluid there? Could it be an empyema? And actually, I've seen this a lot recently, not just in children, but in adults actually in the UK, where they haven't responded to treatment, and actually they've been found to have an enormous empyema.
It's quite often staphylococcal in children, the empyema.
Is it? Okay,
yeah,
I didn't
certainly in my
know that.
experience.
Yeah. Lung abscesses, things like that. And also, as we talked before, consider an underlying problem. Could they be HIV positive? Could this be TB? Could this be cystic fibrosis? Now, I think you looked into the stats for that.
I did, yeah. So it's very common in Caucasians, but they have done some statistics in South Africa where they found that 1 in 2,000 white babies are likely to have cystic fibrosis, 1 in 12,000 mixed ancestry, and 1 in 32,000 Black African babies are affected. So it's much lower in the Black African population. but they're doing more research. So,
Yeah.
you know, there may be more there than is realised. You know,
So it may be that it's yeah, absolutely. It may be being underdiagnosed.
Yeah.
And just because it's rare, it doesn't mean that it doesn't happen.
Exactly.
Somebody has to be that 1 in 32,000. So do think about it. And although we said that routinely we don't do chest x-rays and other investigations, if that child isn't getting better, if you think there might be a complication, well, that's the time then to be considering doing a chest x-ray or sputum culture or an HIV test.
Absolutely.
Yeah.
Okay, just very quickly, because I appreciate this is a bit of a longer podcast than usual. Prevention is obviously key to reducing childhood mortality, and immunisation. So Hib, pneumococcus, measles and whooping cough, they're really effective ways to prevent infections and prevent these pneumonias, along with adequate nutrition. And looking at environmental factors, so trying to reduce parental smoking, indoor pollutions, air pollutions we mentioned before, and overcrowding.
Yeah, absolutely. And then again, children with HIV you should consider giving them daily prophylactic co-triazole to prevent which pneumo was it? Pneumocystis.
Pneumocystis, yes, yes.
Yes, which as we discussed is a high risk for mortality. Right, fantastic. And Joseph, does he get better, Minnie?
Joseph makes a full recovery. Yes, he's absolutely fine. Thanks for asking, Fran. Just at the bottom of
I'm delighted to hear it.
Just at the bottom of the document, we've added a link to quite a useful MSF guidelines for treating pneumonia, which you may find useful. It has drug doses and things on. So thank you very much for listening, and we look forward to having you listen to us again. Bye from me.
Thank you and goodbye.